So I guess on a medicine safety aspect, which is really important and has been identified by the World Health Organization as a major source of harm to people around the world. And it's thought that errors and harms from medications, the total about $42 billion annually. And even on a kind of national level, we can look at preventable adverse drug reactions and harms will total about £98.5 million per annum. And I suppose you could, if you put aside the significant harm to the patients and the people of this country, there's also, as times, as we very well know at the moment, are tough in the NHS in terms of funding. This is a huge amount of money. So this issue both touches on our safety, good clinical governance, the safety of our patients, the quality of our care, but also is about us having a sustainable health service. And it's been shown also that drug reactions are pretty common. 8% in a recent systematic review in primary care, so your GP surgeries. So that's a huge proportion of the population are suffering harm from medicines. We've looked at hospital admissions for these, and drug-related events are common, particularly in those of an older age, particularly with regard to high-risk medicines and those receiving multiple medicines, which is also something that we see as we tend to get older. Unfortunately, as we get a little bit older, we tend to collect diagnosis, and with that, we tend to collect medications as well. So this is a pretty live issue, and for one of the reasons that the Medicine Safety Week is really about is just highlighting the importance of this issue, and of course the World Patient Safety Day as well. So if we could move on to the next page. Yeah, so I just wanted to, I'm sure you're all aware of the Yellow Card Centre, and Yellow Card Centre have, I'm sure, presented to this group before, but I thought it was just important to highlight its role in medicine safety. So the Yellow Card Centre was born out about 55 years ago from the thalidomide tragedy, which involved the medication being given to pregnant women, which hadn't really been sufficiently tested in this group. But the main issue was that there were some concerns about this medication, serious concerns, but it was very difficult for any unilateral or action to be taken to remove this drug from the market. And it was identified that all the actions really were much later than they should have happened. And of course, it resulted in significant harm, which of course some of us are still living with to this day. And out of this recognition, the Yellow Card Centre was born. And this allows the monitoring of medications after they're released to market. Prior to that, a drug would be authorized and really would be left to kind of find its own way with little oversight of what was happening in terms of potential harms or adverse drug reactions. So the Yellow Card Centre was a pioneer of what we would call post-marketing pharmacovigilance, looking at these medications that are in the market. If we look at the NPIS as a service, we collect data about potential harms from medications. Next slide, please, Ella. So what is the NPIS? So the NPIS is a National Poisons Information Service. These are 4 units around the UK, based in Cardiff, of course, the best unit, Birmingham, Newcastle, and Edinburgh. And they provide a 24/7 specialist service supporting healthcare professionals in managing the poisoned patient. So unlike other poisoning services, such as in Australia, Ireland, and the United States, we don't have interaction directly with the public. We give advice to healthcare professionals. That said, we still have a huge number of calls. In 2022 to 23, there were almost 40,000 inquiries to our helplines. And we also have an online database called Talkspace, which is accessible by all healthcare professionals and actually students as well, which gives clinical advice on the management of poison patient. Now, we often think about medicines, and the main topic of this talk will be about medicines, but we also deal with animal bites, plant ingestions, such as mushroom poisoning, very topical. We're coming into that time of year again, chemical issues, and all these kind of things, radiation, etc. So we have a very wide remit, but a large proportion of our work is related to medicines. What we realize, therefore, is that we have an interesting, we say also post-marketing database of potential harm from medicines that we do collect in our day-to-day clinical work. And one of the things that we wanted to look at was the use of Dosset boxes or devices, and if they are associated with harm or the harm that comes to people who are using them. Next slide. Yeah, so I think we've got a partnership really which we are trying to develop now with the Yellow Card Centre, where hopefully if there are signals that are happening seen in Yellow Card Centre data, we may be able to look at our database to try and join up, and vice versa as well. And we've started a regular meeting with our Yellow Card colleagues to be able to support this. Next slide. So that's all from me. And as I said, Ella's done the majority of this work. And I will hand over to your capable hands, Ella. Thank you.
There you go. Thank you. Sorry, I had to work out how to unmute myself. Yeah, thank you, Lawrence. Yeah, so I am just going to present a study that Lawrence and I have been working on, along with Claire from AWTTC, and also Harriet Price, who is one of the lead pharmacists in geriatric patients in Swansea Bay. And the study is looking at using poison sensor data to identify potential safety risks that might be associated with the use of monitored dosage systems in elderly patients. So a bit of background. Monitored dosage systems, if you're not aware, are devices that are provided by pharmacies, usually to aid medication adherence. And these are typically given to elderly patients who are on multiple medications. And so they look something like this. They've got a number of different names, so probably Dosset box is the most common one, but also known as a Nomad, tray, blister pack. And it's estimated that about 64 million of these are dispensed by pharmacies in England each year. But despite this, there is actually limited data to support their use for medication adherence, especially in the elderly cohort. Yeah, just a bit of background. So whenever we take an inquiry in the Poison Service, we will log it in our UK Poisons information database, which looks a little something like this. And so what we did was carried out a retrospective review of all our inquiries from 2017 to 2022. So this was a 5-year period we looked at. And what we did was filtered for all patients aged 65 and over, and where the circumstances were documented as a therapeutic error or a medical error. And I'll go on to define these in a minute. But then we also filtered these further for only those involving the use of a monitored dosage system. So therapeutic error is defined as an incident occurring as a result of the patient themselves or perhaps a friend or family member making a mistake when taking or giving the medication. And then medical error is an incident occurring as a discrepancy by a healthcare professional, including carers during prescribing or administration. And it's important to note that the Poisons Information Service is primarily contacted about incidents of overdose. So we don't deal with any sort of omissions or mix-ups of medications. It is primarily overdose. And in this study, it's only accidental overdoses. We didn't look at the intentional ones. So our results then. So over this 5-year period, we found 394 inquiries regarding 393 patients. And our main inquirers were GPs, so about 40% were GPs calling, closely followed by NHS 111 callers, and then a few from ambulance crews as well. Smaller numbers came from hospitals and pharmacists. And then the majority of the calls came from England, but we also received them from Wales, Scotland, and other regions. So in terms of the demographics of the patients, so we found that there were a much higher number of female patients in our study, so about 67% compared to only 32% male. So we did some stats and we found that this was significant. We did take into account, obviously, as you get older, the demographics do skew towards females anyway. So we used national statistics data to do the stats, and we found out that it was still significant. And then looking at the age of the patients then, so you can see that it does sort of start to peak around 80 to 89, and then drops back off then at 90. So patients within this age category are potentially more at risk. And the mean age of the patients was 81. Cognitive impairment. So I'll talk about this later in the limitations, but it's not something that we routinely collect information on. But where it was reported, this was in 32.3% of patients. So it doesn't mean that the other 70% were not cognitively impaired, but it was only reported in 32%. So incident circumstances then. So the majority of, about 95% occurred in a home or domestic setting, which is what you might expect because these devices are given to aid adherence at home. And then we had some occur in nursing or care homes as well, 2 in a prison and 1 in hospital. And then looking at the circumstances, so remember I talked about the therapeutic and medical error. You can see here that the vast majority of these are therapeutic errors. So it's the patient or perhaps a family or friends that are making the mistake as opposed to a smaller number of medical errors. So sorry, this slide is a little bit busy, but I'll go through it slowly. So we basically went through each of the inquiries and tried to categorize the reason for accidental overdose. It's something we're still refining as we work on the paper, but at the time, this is what we came up with. So you can see for about 48% of these were basically just due to a patient or family member mistake. They simply just mixed up when given the medications or taking them, and it was just confusion. The next sort of most common reason was just medications missing. So maybe a family member comes over, there's medications missing from the dosset box. The patient doesn't remember, isn't sure what's happened. If they've fallen on the floor, we're not sure. But potentially, we would always sort of treat these worst case scenarios if they had been ingested. And then smaller percentages then, so 5% MDS is just, it doesn't match up with a prescription. We don't know where the error's been made, possibly in the pharmacy, but then they may not have received the communication from the GP, but it doesn't match up. And then we've got medications taken from another person's MDS. So perhaps their partner also has an MDS and they've taken it from there by accident. Medications in an MDS are normal packaging. So this we found was mainly where patients have recently been discharged from hospital and given some medication to go home with. And the sort of medication record hasn't been checked and they weren't aware that the medication was already in their MDS and therefore they're now taking it twice. Double dose administered by 2 different people, it's pretty self-explanatory, but perhaps the patient or a carer or family is already given the medication and the patient takes it again an hour later, or perhaps 2 different carers are given the medication at different times. Patient has multiple MDS, so they they can't keep track of which ones they've taken. Patient taking medications as soon as the pharmacy delivers it. So perhaps they've already been given their medication or taken it that morning, and then they get the next delivery maybe at midday, and then they take it straight away thinking that they're supposed to. Care is accidentally given too much. That's self-explanatory. A self-prepared MDS, so perhaps where a family has bought one of these devices and are filling it themselves, and they've made a mistake with that. Medications taken from an old MDMS, so perhaps their prescription has changed, but the old medications haven't been returned to the pharmacy for whatever reason, and they're lying around the house, so they're being taken again. And then these are in really small percentages, so only sort of 1 to 2 inquiries involve these, but changes to drug preparations, so tablets to capsules, for example, they don't recognize them and they're taking them again. Patient gains access to an MDS, which is usually locked away, so usually only the carers can administer it, but they've gained access. And there was one case of an electronic MDS, so I believe it gives sort of automatic alerts when it's time to take the medication, was alerting too often for whatever reason. So in terms of the medications themselves, we found there was 270 different medications reported to have been taken. And the maximum number of different medications in a single ingestion was 12. About 27% of patients ingested 5 or more different medications in accidental overdose. So looking at the medications then, obviously we had a huge list. So I've just put the top 20 in a table here. Sorry if it's small. But essentially, there are a few there that are high risk medications in elderly patients. So for example, you've got bisoprolol, amlodipine, and ramipril, which are your cardiotoxics. So it's obviously an increased risk in elderly patients who've taken these in excess. And also anticoagulants as well, so clopidogrel, apixaban, and rivaroxaban. So these obviously increase the risk of bleeding, which is a concern in elderly patients, especially if there's a risk of falls and things like that. So yeah, bisoprolol was the most common one taken. And then there's a couple of different sort of types. So obviously the cardiotoxics and anticoagulants, but there's also analgesics, paracetamol and aspirin are up there as well. So looking at symptoms then. So the top 20 features of toxicity reported. So the majority of patients, thankfully, were asymptomatic. So 311 out of 393 were asymptomatic. And where symptoms were reported, these were in quite small numbers. So the most common drowsiness was only reported in 16 cases. So where reported, the symptoms include sort of neurological features. So you can see here, so we've got dizziness, drowsiness, confusion, and fatigue. I think it's also important to note that sometimes the features of toxicity are quite hard to distinguish from the patient's normal sort of state. So that's something to bear in mind as well. This might not be new because of the accidental overdose. It might be something pre-existing, but there's no way for us to tell. So yeah, you've got your neurological symptoms, but also some GI upset as well, vomiting, abdo pain, diarrhea, and then some cardiac features, so hypotension. We've got bradycardia and tachycardia there as well. But for the most case, they are asymptomatic, which is good. So for each inquiry, we assign a poison severity score, and this ranges from none to fatal. We've got minor, moderate, and severe in there as well. So you can see the majority of the calls, we assigned a poison severity score of none, so they had no features. And then we assigned minor for 57 of these, and then moderate 4, severe 2, and thankfully there were no fatal cases. So there were no incidents of death in our study. So then obviously our job is to give management advice to these healthcare professionals dealing with the patients. And so looking at the referrals that we advised, so 132 patients we advised nothing, so they were fine to stay at home, continued home monitoring. We wouldn't expect toxicity. But you can see here 200 patients were advised an A&E referral as a precaution. So going back to our symptoms then, 79% were asymptomatic with a PSS of none. But of these, 47% were recommended an assessment in A&E. And this is due to the fact that their age and also the type of medications that they've taken. And so I've just included a little snippet from ToxBase. So ToxBase is our online database where we get our management advice from. And this is an excerpt from the bisoprolol entry. So essentially, medical assessment is recommended for ingestions in the following patients who are treatment naive or have taken more than their therapeutic dose. And that includes, point C here, elderly patients, or if they've got a significant cardiac history. So obviously that's the reason why we are referring so many of these patients to A&E, despite the fact that they're asymptomatic. They're still at a high risk, especially if they're still within the minimum observation periods. We would advise they go to A&E for a period of observation. And then we also have a second sort of criteria for referring these in. So the bottom sentence there, all patients who've exceeded their prescribed daily dose of 2 or more cardiotoxics should be referred for medical assessment, irrespective of the dose. So going back to the medications list, for example, if they've taken even 1 extra tablet of bisoprolol and amlodipine, that's an automatic referral to A&E as a precaution. So you can see why we're sending so many of these in. But as we know, A&E referral for an elderly patient is not without its own risks as well. So this is something to consider. So our conclusions then. So the majority of these are occurring as a result of a therapeutic error and are occurring at home. Patients aged 80 or over might be at a higher risk of these incidences. And like I mentioned, although 80%, or about 80% remained asymptomatic, just over half of the patients in this study were referred to A&E. So there are some limitations to this study. Obviously, poison center data is only retrospective. We also don't routinely collect data about whether a patient uses an MDS or whether they have any cognitive impairments. And data collection relies on the quality of the inquiry logged, and the amount of detail included might differ between the scientists. And it's also due to the information that the caller volunteers as well. So they might not mention that they use an MDS. And then it's important to note that this is reported data, not actual incidence data. Obviously, the Poison Service won't be contacted in every single one of these cases. So unfortunately, it's likely to be an underrepresentation of the amount of times this is happening. And then it's important to note the lack of outcome data as well. So although we are referring a lot of these patients into A&E, we don't routinely follow up to check if they actually do attend A&E. So it's possible that not all of these actually go in, but just due to resources, we don't have the time to follow up every single one of these cases. So future work then, it would be really great if we could do a prospective study, and this would allow for more accurate data collection then. So we could do up some predetermined questions for the scientists to ask at the time of the call. So that could include, is the patient cognitively impaired? Is this from an MDS? And we could also put in a protocol for mandatory follow-up of A&E referrals. And then, it would just be great to continue the multi-organization collaboration to increase medicine safety and to raise awareness of the potential safety risks of using an MDS in elderly patients.